So first of all, thank you all very much for coming. I'm actually really pleased to see how the room continues to fill up, which I think speaks to the ongoing, hopefully the ongoing value of these sessions. I'm Carmen Mueller. I'm a relatively new staff at McGill doing minimally invasive and foregut surgery. And I was originally going to talk about all ERPs for all of Foregut surgery, but then I realized that that's going to be far too long. So I'm just going to focus in on stomach ERPs for malignancies, partially because that's still a pathway that we have yet to fully implement, despite the long history of ERPs at the MUHC. And there's some good reasons for that, and it's just because the program has gotten so popular that you have to get in line now to actually develop these things, and the committee is at its full capacity. So this is one of the things that's on the docket for this year, and I'm tasked with moving that forward, partially because I volunteered, and so I thought I would talk about some of those things. Okay, thanks. I have no disclosures. So just a little bit of background. The gastrectomy has been around a long time. The first successful gastrectomy was done by Bill Roth in 1881 in the Allgemeine Krankenhaus in Vienna, and there he is. He's being watched very intently. And the patient that he operated on, he wasn't the first one to attempt gastrectomy, but he was the first one whose patient actually left the hospital alive. And it was a 48-year-old woman with gastric outlet obstruction from a distal cancer. And she had a hand-sewn Bill Roth 1 using 54 silk sutures for the anastomosis. And she was actually allowed to have a teaspoon of buttermilk every hour starting on post-op day 2, which makes you wonder, is this perhaps the beginning of ERAS all that time ago? But no, her length of stay was pretty long, 26 days, and she certainly didn't have any anesthetic ERAS. She was anesthetized with ether, chloroform, and alcohol, so it makes you wonder what her depth of anesthesia actually was there. Since that time, gastric surgery has evolved quite a bit, but a lot of the traditions still remain. And so NPO at midnight, certainly concerns about delayed gastric emptying and retained food. Most patients undergoing open surgery, maybe not, they got an epidural. Urinary catheters, mandatory, usually for days, making ambulation very difficult. NG tubes, mandatory for days, maybe even with a second tube for feeding. And the whole patient experience is wrapped around immobility and nothing by mouth. So I'm happy to say this isn't one of my patients, but a picture I found on the internet. But if you can't read it, he basically says, I love you all and I'm on my way, but this is terrible. And it makes you really think that perhaps we could be doing better in the care of these patients. And so ERAS certainly speaks to that. And my talk was made a lot easier by the fact that the ERAS Society has actually very recently published guidelines specific to gastrectomy for malignancy. And Dr. Carley, who's here, was part of that. And this was published in 2014 in the British Journal of Surgery, and very nicely summarizes a lot of the evidence around these. And I wanted to just focus in on the things that are particular to gastric surgery, because a lot of ERAS is universal and portable across all diseases. And so the 4 key areas I thought were nutritional support in these patients, the use of NG tubes, the use of perianastomotic drains, and the surgical approach. So nutritional support, well, malnutrition is a big issue in any surgical population. It's associated with higher anastomotic leaks. It's associated with greater incidence of surgical site infections. And severe malnutrition, according to the ESPEN guidelines, is any of these 4 things. So weight loss greater than 10 to 15% in 6 months. Many of our patients might meet that. And albumin less than 30, very low BMI, and frailty. And this was a paper out of Japan just last year, looking at a series of 800 patients. And they looked at the difference between their malnourished patients who met these criteria and their regular patients. And the malnourished patients had a lot of similarities. They were significantly older. They had a significantly lower, well, higher, I guess, ECOG score, so poorer performance status, and they were more likely to require a total gastrectomy. And what's interesting here is that in Japan, as we know, there's a lot of early gastric cancers. It's significantly more patients who met the malnutrition guidelines had locally advanced cancers. In this series, that was 29% of these patients. Well, there's a lot of good reasons that gastric cancer patients might be malnourished. There's the cancer cachexia to begin with, but then they also suffer from obstructions, early satiety, reduced gastric volume in the case of Leonitis. And when I looked at our data from I picked two separate years, we're far apart, 2020 and 2015, and there were about 60 cases that were pure gastric, not GE junction, just true gastric cancers. 31% or 51% of these cases were locally advanced, so 29% in the Japanese studies, 50% in our population, and out of these, 3 for sure met the criteria to be severely malnourished. And how do we deal with these patients? Well, this is a snapshot of the oncology nurse's assessment in our institution of one of these malnourished patients. And basically, it says that she's inadequate energy and protein intake. She's progressing to anorexia. She had a severe social difficulty. She actually had a son who had some sort of eating disorder who ate all her food. He was over 400 pounds, and she couldn't keep any food in the house. He was completely financially dependent on her, so that didn't help. Difficulty preparing meals, etc. Lost 8% of her weight in the last 2 weeks. And she's going to progress to deteriorate if we don't do something. So here are her recommendations. Encourage a regular high-calorie diet. Give her some education around what that means. Encourage grazing throughout the day, so not just eating 3 meals, but eating continuously. She made a referral to Meals on Wheels for the patient, actually called them to bring the food in. That's what the nurse did herself, and liaise with other social services. And so a lot of things going into just helping this patient not lose any further weight. And so it's really important to identify the malnourished patients who are at high risk, encourage supplemental high-protein energy oral intake if at all possible, and then the usual carb loading and clear fluids before the actual surgical procedure as we do for all the other cases. And in rare cases, potentially as a bridge, perhaps considering enteral tube feeds or TPN, although we often don't have to do that. So if pre-op nutrition is important in these patients, certainly post-op diet is also important. And this was it's not a new study, this is 2008 in the Annals of Surgery out of Scandinavia. And I picked this one, there are many studies out there, but this is the one that's done. It's a good quality study, and it's done in Western type patients. So a lot of the studies come out of Asia, and we can say maybe they're not very similar, but this one comes out of the West. They took 453 upper GI and hepatobiliary cases and randomized them to food at will on post-op day 1, regardless of whether it was a Whipple or a total gastrectomy, versus that inserted a feeding tube and fed them until post-op day 6 when they were allowed to have food at will. And they found out of 77 total gastrectomies and 82 subtotal gastrectomies, there was no difference in in-hospital complications. There was actually no difference in any surgical group. And there was a decreased discharge complications and decreased length of stay in the food at will group. And then there's many other studies, mostly out of Asia, that corroborate these results. And so what we can conclude from this is that food at will for the gastrectomy patients is not harmful. There's no increase in leak rate, there's no increase in aspiration pneumonia, but you should be careful. You should be able to watch your patients just like you would anybody else, and advise them to go slowly and make sure that they're tolerating their diet. And then if you see an x-ray like this after your subtotal gastrectomy on day 2, that you do something different. This patient is not on pathway anymore, and you need to intervene. So if we're giving patients food on day 1, what do we do about the NG tubes? This one's quite straightforward. Lots of data out there. There are 2 meta-analyses of 8 randomized controlled trials, over 1,000 patients. Routine NG tube use in gastrectomy patients is of no benefit, and it may actually increase pulmonary complications, particularly aspiration pneumonia, and it delays advancement to diet, which delays discharge. So there's no role for this routine basis any longer. Perianastomotic drains is a little more dicey. Depending on the operation you do, there can be at least 2 to 3 sites where things can leak. And the most devastating one, I think most people agree, is the duodenal stump. If that blows out, you're in for a lot of misery. And so people are very concerned about draining this. Now, there was a Cochrane review done on abdominal drains. Sorry, I'm freezing, which is why my voice is shaking so much. I don't know if anyone else finds it cold in here, but I'm freezing. Basically what they concluded was that the evidence for drains, for or against drains in gastrectomy is very weak. Not a lot of good quality trials. There are only 4 RCTs, not a lot of patients. In all of these randomized control trials, the leak rate was only reported in 1 of them. But what they can conclude is that there's probably no benefit from the routine use of drains. It may increase the length of stay. It may lead to some drain-related complications. However, in select cases where there's a concern or something, it may still be appropriate. And the reality is this site, although if it blows out can be a devastating problem, is not that difficult to drain by interventional radiology. So in the rare case that this does happen, you can do a percutaneous drainage. Lastly, surgical approach, so laparoscopic versus open. I'm talking to the converted. I think we all agree that if you can do something laparoscopically, you probably should. But what's the evidence for that? Well, also not great. Anytime you see this many meta-analyses and a lot of randomized control, not that many randomized control trials, it means that the evidence isn't that clear. Most of the data is for early gastric cancers and mostly for distal tumors, which are not typically the patients that we see in North America. There may be some benefit in fewer postoperative complications, specifically less blood loss and fewer pulmonary complications with the laparoscopic approach. There's some trends to increased oral intake, but I don't know that makes a lot of sense. I think that depends on when you choose to feed your patient, not really on the surgical approach, particularly in the upper abdomen where ileus is not an issue. There's a potentially decreased length of stay, and it seems that lymph node harvest can be pretty much equivalent. But there are some significant challenges to laparoscopy for gastric cancer. Many of the tumors are locally advanced. When they are locally advanced, they often invade other organs, which are difficult to resect, particularly posterior invasion into the pancreas, the tail of the pancreas, or the spleen, the transverse colon. They can have very bulky and extensive nodal involvement. So you might be able to get the same number of lymph nodes, but are you getting all the lymph nodes that you need to get in those cases? That's a concern. And we don't have any long-term oncologic outcomes or quality of life data for these patients. So what do I do, or what do we do where I work? We consider patient factors, the tumor factors, and your own personal technical ability and what you think you can achieve. There are 2 situations where I really find that the laparoscopic approach is very difficult and probably inadequate, at least in my hands. One is, this is a picture of the D2 lymph node stations in gastric cancer. There's along the hepatic artery here, where anteriorly, the 8A lymph node, that one's pretty easy to get out laparoscopically. It's right in your face, and it's not a problem. And all the nodes around the celiac and the left gastric artery we can really get out nicely. But the one behind the portal vein is really tough. And if that one's involved, I don't have a very good technique for getting that out. I want to put my hand in there. You have to push the portal vein up in your face, take a pair of mets, and really chip it off. I don't have a good approach for that laparoscopically. If anybody does, I'd be very happy to talk to you about it, because for me, if a patient has that node and I really need to go after that node, or there's bulky nodes around behind the portal vein, for me, they need an open operation just to get adequate oncologic control. Secondly is linitis, which we see a lot. Very heavy stomach, usually very stiff, hard to manipulate, hard to get underneath and lift it up and get a working space. And they're very often more invasive than you think. So this was a case that my colleague did yesterday, actually. I missed it. Sounded like a pretty good case because it looks okay. You'd probably be able to get a margin, but actually it was invading the spleen and the tail of the pancreas. So that was a left upper quadrantectomy, basically. And again, I don't think that's very difficult to achieve a good oncologic outcome laparoscopically. So someone told me once to try to match the procedure to the clinical scenario and not the other way around. I think that's really good advice, and we have to be using all of these elements to try to achieve the outcomes that we want to achieve. So I try to think about that. So what do we do? So right now we don't have a formal pathway for gastrectomy, but we have a care plan, and we're working on implementing the formal pathway. Post-op day 0, there's no NG tubes. We're trying to get away from drains. They sip water, they sit at the side of the bed, they have multimodal analgesia, and they only have a Foley if they have an epidural. Post-op day 1, the IV is hep-locked, the Foley comes out, they start drinking at will, ambulate a lot, multimodal analgesia continues, and this is regardless of whether they're laparoscopic or open. Post-op day 2, if they have an epidural, we stop it. They are on oral pain meds, they're eating, ambulating a lot, we start talking about going home, and then on day 3, regardless laparoscopic or open, we try to get them home. So how is that looking? Well, in 2010, there were 24 curative intent resections for gastric adenocarcinoma, of which 2 were done endoscopically with no surgery. There were 29% done laparoscopically. 63% were done open at that time, and only 66% of them had locally advanced tumors. The tumor stage was about 50-50, early versus locally advanced, and the median length of stay was 7 days. In 2015, there were a few more cases. More of those approached endoscopically. More of those, out of the ones that were not achievable endoscopically, they were done laparoscopic, unless they were locally advanced, in which case most of those cases were approached open. The distribution of tumor type was more or less the same, and the median length of stay has gone down significantly to 4 days. So in summary, change is hard, but the advice would be for gastric surgery to identify and deal with malnourished patients aggressively, start oral intake early after surgery, no use of NG tubes, routine use of drains is not necessary, and whenever feasible, consider a minimally invasive approach. Thank you very much.